in order to break away from that vicious cycle, we have to go back, improve the supply of primary care physicians so that they can address our health aspects before it's too late where we need specialists.
A safe haven for innovators to go off the rails. Welcome back to the Off the Rails podcast, a show about the runaway train that is our healthcare system and the innovators working to derail it. This is your host, Sydney Haytoff, and today we're joined by Rohan Kulkarni. Rohan, thanks for joining us.
My pleasure, Sydney.
I'm really excited to have you on. We were introduced through content that I saw that you wrote for HFS. I think you have an incredibly unique perspective on the industry, healthcare industry, and some of the trends that are taking place and that have been taking place over the last 5 to 10 years and hitting an inflection point over the last couple of years here. First off, where do you work and what's your overall occupation?
Absolutely, Cindy. Thanks for the opportunity to chat about something that is near and dear to me. As far as work, I work at HFS Research. HFS Research is a boutique analyst and research enterprise. We've been around close to 15 years now. Our claim to fame, amongst many other things, including the creation of the acronym RPA, which is Robotic Process Automation, by Phil First, our CEO, many number of years ago. At HFS Research, I lead the healthcare and life sciences practice, having been in the healthcare industry now close to 2 decades in various different avatars at the health plans, health systems, service providers, consulting, and so on. So,
awesome. I had no idea that RPA came from HFS. That's awesome.
It certainly did. Yes, very proud.
I have a whole long background and history in that, but we won't dig in there. But cool. Thank you. What is your favorite food?
As I evolve in terms of age and maturity, that continues to change. But right now, I'm digging sushi.
Yes, love it. I love sushi. Any particular favorite roll? Type of roll?
Rolls don't fascinate me as much as the sashimi, just pure, raw fish, if you would, with just a dash of this and a dash of that, right? I try to avoid the American way of eating sushi with a whole bunch of soy sauce and wasabi and all of that.
Yeah, I'm guilty. We call it white people sushi among my friends. I'm black and white, so I get to say that, I guess. But no, omakase is awesome. And I feel like it's one of those things that is out of reach to some extent for people, either because they don't really know that it's an available option. And obviously in some cases it's super expensive, but awesome. Love sushi. And do you have any pets?
No pets. No pets.
Got it. And what is your perspective on direct primary care? Jump right in here.
Yeah, absolutely. So let me start with primary care and then I'll get to direct primary care, right?
Sure.
Just fundamentally, when you think about primary care being the foundational element of addressing health and wellness and even care delivery for a vast majority of people, I think in the US, we have absolutely missed the mark on it. When you look at OECD countries at this point in time, some 35, 39 odd countries, typically speaking, 60, 70, 80% of the entire clinical workforce is primary care. And then laid upon that is a level of specialization, right? Whether it's cardiovascular, whether it's oncology, whatever specialization. In the US, we flipped it around. We have almost 70 to 80% of all of our clinicians to be specialists, right? We only have about, I think the last number I've seen is about 27% of clinicians are in family care, family medicine, or primary care, right? I give this level setting because in this context, direct primary care needs to be thought about very differently, right? So for me, direct primary care is that opportunity where I, as a consumer, whether I'm healthy or I am sick, so I call myself a health consumer, whether I'm an employee, whether I'm a member, whether I'm a patient, whatever that avatar is, I'm a health consumer. So to me, direct primary care is my ability to access a clinician directly for primary care purposes. And from a primary care clinician standpoint, my expectation is to address not only that point in time, disease condition, but also to help me address my health and wellness needs. This is kind of the context that I look at. And in terms of modalities, right, I also want it to be affordable. I want it to be accessible. I want it to be equitable. What I have seen over the last few years now, particularly being energized post-pandemic, is a resurgence of what I'm calling digital health enabled primary care. So to me, this is where primary care physicians are becoming more independent. It's all driven by technologies, in some ways divorced from large health systems and also divorced from health plans. And so these are subscription-based models, multimodal in terms of delivery, right? Brick and mortar, virtual, asynchronous virtual, synchronous virtual, and also in the 24/7, and there's typically a formulary of the most prescribed medications available as part of the subscription. So this to me is that the package of direct primary care, at least the sort of the beginnings of what I think is the version 2.0 or version 3.0 of what direct primary care ought to be looking like.
Got it. Okay, thank you for that very thorough response. And yeah, let's dig in from there. So 20% of physicians are family care, primary care internists, let's say. And I heard recently that Stanford, I believe it was, this is the first year that they are either not graduating any primary care docs or are not taking or don't have any primary care docs in the incoming class. And so definitely representative of a larger trend. The country, I would say overall, is concerned about an impending primary care shortage. And clearly there's reason to be concerned there. There are ways I think that are taking steps to augment that issue, but obviously still represents a big one considering the fact that, like you said, in other countries, the paradigm, the density is shifted more in favor of primary care. And seemingly that was the case just a few decades ago. And so it leads one to question what the incentives are, what the tectonic shifts taking place or that are in place or that are causing this shift or that have caused this shift over the last few decades. And obviously the number one that comes to mind, and I think the one that's been the most hottest or contested, debated, is reimbursement. And so this concept of primary care docs not getting the same reimbursements as their counterparts in specialty care. Some argue that the difference in training is what justifies the gap in reimbursement, and thinking that specialists primarily spend a few more years in fellowship and then go on to get their board certification, and that additional subspecialty or specialization justifies the added reimbursement. But when you look at the difference in terms of gross collections for specialists, whether it's ortho, cardio, neuro, vascular, nephrologist, etc., it's not close. Like we're talking 2 and 3x in many, if not most instances. I spoke to a primary care doc just yesterday who is clearing closer to 200K a year, and he splits his time between health system affiliation, not employment, but health system affiliation and private practice, which is fairly unique. And I would say he's of a dying breed today, as most primary care resources have been gobbled up by larger health systems, except for the ones who are defecting and now taking the lead with DPC. But my experience on the revenue cycle side of the world shows that specialists on average clear closer to $1 million, or at least surgeons clear closer to usually way more than $1 million in gross revenue, depending on the region and the setting in which they're rendering care. But yeah, reimbursement, obviously, I've always been one to follow the money. And I think you'd probably say the same, just given your background. Any high-level thoughts on how, from your perspective, how reimbursement has caused this trend and what we can do potentially to stop the runaway train and take it off the rails there?
Yes, so reimbursement certainly is a driver, but I'd actually step back a little bit. I'd go back to medical school.
Yes.
I think the way we've structured medical school requires a relook. When you put potential clinicians through school for 10, 14 years, just basic medical school, residency, fellowships, and so on and so forth, it is hard for us to then argue that they ought not to be trying to recover their investments, because nobody's coming out of medical school debt-free, right? It's unheard of, right? So they're in the process, and by the time many of them come out, they're in the mid-30s, right? So when you think about their runway, there's not a lot compared to a lot of us who get into the work life maybe 10 years before they do. So that's number one, right? Number two is when it comes to fellowship programs and residencies and so on, there's an opportunity to begin to throttle this. Why are we having so many residency programs for specializations and so few for primary care, right? Everybody, when they finish medical school, they have the basic medical knowledge where medicinal information is available for everyone. They choose specializations, back to your point, because of the compensation opportunities, right? There is that foundational element where we ought to be able to should be addressing, right? We shouldn't be putting people through school for 14 years. I think there's an argument to be made that so much of training is why America probably has the best clinical care, par none, in the whole world, irrespective of the endemic issues that we have in the system. But when it comes to pure clinical care, we are unmatched. That is the argument I would make. And that is because of this enormous amount of training. But I would argue that with the amount of technology that is at hand now, we ought to be able to throttle back, allow some of these folks to get into the market a lot sooner, which will help address the clinician shortage that we are facing. And two, by adding supply to the growing demand, I think just from pure economics, we may be able to address some of those cost issues, right? Then comes the reimbursement aspect of it. Look, I think there is clearly an opportunity to streamline some of this. As a society, we have chosen to treat an oncologist higher, better, greater than a primary care physician. I think there are probably arguments to be made that societal understanding itself is incorrect. But look, if you are suffering from cancer and you're going through chemo, it is unlikely that you're going to subscribe to my school of thought, which is clinicians are clinicians. Some have training in something and they can help you with something, and others have training in something else and they can help you with something else. Again, we are a capitalistic society, right? We are extremely biased towards ensuring that where we can moderate, manage that supply demand, that is exactly what we're doing. At this point in time, the demand is extremely high in America. Last time you and I chatted, I mentioned to you 6 out of 10 of us have a chronic condition of one sort or not, right? So this kind of chronic condition will then create other kinds of comorbidities, which will clearly require the help of specialists. And so there goes the vicious cycle. In order to break away from that vicious cycle, we have to go back, improve the supply of primary care physicians so that they can address our health aspects before it's too late where we need specialists. So I don't think this is a linear equation. Reimbursement certainly play a part, but I think it's a polymath problem that we need to be addressing. And so that's where my head is.
Got it. Okay. And that makes a lot of sense. So that taking an economics perspective and going off of what you said about capitalistic society, talking about supply and demand, essentially what you just mentioned there is that we have a greater demand for higher specialized care or coverage, and it will continue to trend in that direction. Then follow-up question is, do you believe that the need for highly specialized care comes from a way of living that is not optimal? And I guess then the question becomes, to what extent do the outside factors, if we want to look more broadly at cultural and socioeconomic, social determinants of health, to what extent do they impact the overall economics of our healthcare system? And what, if anything, can we do to curb that?
Yeah, no, we need to take a whole of a society approach.
Yep.
And the whole of the society approach will pay dividends, but it will pay dividends in the long term. It will not likely pay dividends in the short term. And I think, again, I'm not an expert in capitalism, even though I guess I've been practicing it most of my life, consciously or subconsciously. There is a propensity for capitalists to want to see quick and early returns. And that is unlikely, right? Because we have to change the way we live our lives. And we're unprepared to doing that at different levels, at a personal level, at a community level, at an employer level, at a state level. We continue to perpetuate behaviors that might be comfortable and convenient at that point in time, but they're extremely detrimental to high quality life in the long term, right? One example that I'll call out is the fact that the US government, even today, provides sugar subsidies. What on God's earth are we providing sugar subsidies for, right? The entrenched forces that ensure that those subsidies will stay are much more powerful than what you and I can bring to bear by evangelizing the idea that sugar invariably, whether in moderate quantities, high quantities, is a risk factor to drive diabetes. Just, it's a known thing, right? Yet we do this. We have the propensity to eat more red meat than not. Every pound of red meat contributes to about, is the equivalent of driving about 2 miles or so in an internal combustion vehicle, right? I'm not suggesting or evangelizing that we stop eating red meat, but I'm certainly trying to bring awareness to the fact that we need to be much more cognizant about what goes in, because this is not only about addressing climate change, but it is also a driver of high cholesterol. So there are all of these connections. And again, in America, we seem to have a pretty low health, right? Various different calculations suggest that our health IQ is below 10, right? On a scale of 1 to 100, we're below 10. So we are just not a very aware society. I'm not saying we're not smart. We're extremely smart people, but we're not very aware about these implications to personal as well as our community.
I totally agree there. And it's interesting that you bring up red meat and sugar. These are topics I speak about with my father quite a bit. He's an evangelist for plant-based diet. He's not 100% plant-based. I'd say like 99%, but we have similar conversations. And I think it brings up a larger point around considering the whole person with regards to care and their entire kind of life cycle that contributes to their healthcare or lack thereof, and the journey that they'll have to endure, depending on what some of those comorbidities could be that they accumulate over time. This concept of holistic care or a holistic approach, it's really a holistic consideration, is very timely as the industry continues to, and I would say we've been doing this for the last 10, 15 years, but continues to figure out and wrestle with this concept of value-based care and how to judge it or how to implement it, what it is. To me, this concept of value-based care, obviously quality over cost, people talk about it in the context of outcomes, but if we maybe instead of looking at it based on outcomes of episodes, maybe we look at it as the whole life, and your whole life is an outcome based on the inputs, whether that's food or exercise, etc. And it's interesting to consider, going back to DPC where we started, this concept of subscription primary care and essentially all-inclusive primary care and its ability to drive value and streamline access for the, I would say, most common health conditions and symptoms issues. Yeah, it'll be interesting to see how as the world shifts from this fully insured world more to the self-insured world, or from group sponsored insurance and group plans sponsored by employers to more of those employees shifting towards individual coverage through ICHRAs now that that mechanism is available. It'll be interesting to see how the commercial payers and the country overall starts to respond to the opportunity that is, holistic care. We've seen it with functional medicine and some of these more novel offerings in that regard. We're seeing it in longevity care, somewhat tangential or parallel specialties, if you will, to primary care. But it's yet to be seen. Like, we've been talking about value-based care for as long as I've been in the industry, and that's now going on 13, 14 years. And I feel like we're only just starting to scratch the surface of what that could mean. But when you think about it in terms from a very core level, yeah, I think the cost goes down as you take a more wide-ranging approach towards considering the inputs. And yeah, there's some claims data to support that, and claims data to support that when you put primary care or DPC at the front of a health plan, that it will save the plan money in terms of triage and hospital visits and potentially unnecessary specialty referrals, because the thought is that primary care docs practicing at the top of their license can address most symptoms or issues, and that we've shifted away from that just given the financial incentives. But when you think about it at a core level in terms of what drives overall health, it's maintenance, and it's a consistent effort to live a more, I don't know, healthy life. And I guess we're just talking at a high level, but it makes sense that this concept of subscription care and kind of all-in coverage so that you have access, so that it's easier to maintain your health makes sense. And I guess from what the question that I'm getting to here is, what have you seen, given the research that you've done, that supports this shift towards, or the concept of value-based care? Is there anything that excites you in that space, given your thoughts around taking a more intentional approach on the front end with regards to inputs?
Sure. So the concept of value-based care can be, I think you can draw a line to mid-70s when CMS started exploring and experimenting with the ideas surrounding value-based care. This is 2024. So we're talking about literally close to 50 years of value-based care. I would therefore argue that value-based care has failed. I would argue that CMS needs to stop screwing around with value-based care and reconsider the framework, reconsider the construct for the 21st century. Value-based care is an insurance construct. It is not a care delivery construct. Given where we are from an insurance standpoint, which is to suggest that literally half of the country's population is underwritten, the medical risk is underwritten by the government through Medicare or Medicaid. Another 25 to 30% of it is underwritten by employers. Right? Only 20% or so is underwritten by health insurance companies. Right? So that for-profit idea of insurance has gone away and continues to decline. So given the fact that underwriting now is more a function of addressing health and healthcare needs, this is a great opportunity to begin to divorce ourselves from unsuccessful and failed concepts like value-based care. Period. That's my bottom line. I don't understand why we keep talking about value-based care. How long more do we need to screw around with value-based care before we recognize that it is not a working concept anymore? I'm sure many of your audience, as well as mine, will not agree with me, but that's fine. 50 years is too long a time period for us to test, experiment with this concept of value-based care. So I'll put a pin in that. Now, there is no gold standard in the world that we can aspire to when it comes to care delivery, right? Everybody's trying to experiment. Everybody's trying to figure out how is it going to work. And it makes sense because even though people are people, but people in different parts of the world have different aspirations, live differently, eat differently, and so on. And therefore, the way their care and health and care needs should be addressed are a little different. But I would argue that we may need to go back to, and I'm going to use the term HMO just to make my point, not because I'm a fan of HMO or anything, but the idea that there needs to be a clinician quarterback in our lives, or a paraclinician quarterback in our lives, right? Somebody who knows you, somebody who's invested in your health, somebody who cares about you, right? That one person. That could be a primary care physician. It could be a nurse practitioner. I don't care. It has to be somebody who is in constant contact with you at some level, whether it is digitally enabled or manually enabled. Again, doesn't matter. These tactical constructs we can certainly debate and discuss, because in rural communities, maybe it needs to be more manual. In urban communities, it could be digital, right? We could figure and reconfigure some of this. But that idea that somebody cares about me, somebody is looking out for me from a health and care standpoint, right? Look, we went through COVID. The pandemic took maybe 2-3 years of many of our lives, if we were fortunate enough to survive. We lost 1 million amongst our fellow citizens here in the US, right? During that kind of a pandemic, my clinician, my primary care physician never reached out to check if I'm alive and work and kicking. My health plan never bothered, right? So we've created a construct where we're fundamentally rewarding for lack of care. And yet we have the chutzpah to talk about healthcare. It just doesn't make sense to me, doesn't compute. So if we're talking about a new construct or a different, possibly working construct, I would argue that we need to have that quarterback concept, right? And that quarterback concept should not be fee for service for sure. It should be some form of a subscription-based model where no matter what, X amount of dollars are being spent on this primary care construct, and they're responsible for your health. Now comes that idea that, oh, do you know if you're getting value or no value? I think you will, right? If you're getting sicker, or the number of patients who go see this particular primary care physician have a high mortality rate, it's not working. In today's day and age, we've got Yelp everywhere for every darn thing. And there's ZocDoc for clinicians, right? Let the market figure it out. The market will tell you that this is a good doctor and this is not a good doctor. That's it.
Yeah. Okay. Wow. So totally agree. And thank you for that. It's interesting to hear you use or refer to HMO in the context of establishing that quarterback and that resource that is incentivized to guide you essentially through your care journey and life journey. And HMOs, and obviously you preface it the way you did because HMOs have been villainized, I'd say, but to your point, having the primary care at the center, at the front at the core with the patient in the middle of the model is something that we can definitely learn from and expound upon. And it's cool to hear you say that because I often, conversations talking about what the future of care looks like, often talk about the ability to take the good that was introduced through traditional managed care. And I think that's really what we're getting at when we talk about this concept of health maintenance and HMOs is managed care at its core. And what is managed care? It's having someone incentivized to manage your care, i.e. guide you. And to your point, the traditional reimbursement infrastructure, the reimbursement models essentially perverted that concept of having, the patient-centered, essentially it's like that PCMH model to an extent where they have the primary care as a resource in the front. It perverted that from its original intention into using primary care as like a gatekeeper, but in a negative sense, as they called them, like the referral engines. And I think that's why primary care was bought up. The acquisitions amongst primary care providers and practices accelerated in the last 10 plus years. I think they were the first victims of the PE wave. And it came down to the fact that they were the ones who dictated the referrals, and to own the primary care was to own the patient's journey and impact reimbursements downstream. And I think that is where the misaligned incentives took hold.
Sydney, if I might interject for just a quick second, I think when we think about the HMO model versus the way I've been thinking about it, right? It's not as binary, right? With HMO, your primary care physician basically said who you go see, when you go see, and that was it, which is why it got villainized. My idea is that they are your guide, they're your counselor. But if you say, look, I don't want to come see you, Dr. Primary Care, I just want to go see the orthopedic, go for it. And so we're putting onus on the relationship with the clinician and the patient to a point where the patient says, look, I need you to tell me what I ought to be doing in this situation. The only reason I'm going to take my own decisions because I don't have faith in you. And this is where I go back to the ZocDoc notion, right? I don't have faith in you, therefore I'm going to go see another primary care physician. So I'm going to change my quarterback. So this is, let the market forces take care of it, right? Good doctor, number of patients, because the outcomes are good. Bad doctor, go do something else.
Yeah. And it's crazy because this concept of consumerization of healthcare and giving consumers, helping patients across the chasm from inactive or passive patient into active consumer, informed consumer. One of the things that's missing there is data. It's one of the big kind of pushes around price transparency and allowing those market forces that we've traditionally seen in the context of free market capitalism. But that same concept of supply and demand, let that dictate the consumer decision making. And I think that the price transparency rules have accelerated consideration in that regard. Things like what we're working on at Mishi, creating the market and essentially creating that direct connect to allow the buyers to purchase from sellers directly without that intermediary influence. That I think will start to accelerate the shift towards the market-driven decisions. I think we're still it's going to require an infrastructure change, and that's why we've taken the approach that we have towards driving that, is because we can't usher in the future on old school chassis. And we're trying to get to a place where we don't need roads, but we're still riding a bicycle. And so I think that it'll be awesome to see how we bridge the gap. And that, I think, is what potentially you touch on when we talk about the generational opportunity that does exist within the self-insured employer market, and self-insured employers now representing the largest buyer of care in the country, having edged out Medicare recently. I want to dive into that and spend the rest of our time there. But real quick, just to put a pin in this concept of HMO. Yeah. To your point, the physician's resource, that center, front and center resource, quarterback, under center, front and center, quarterback, under center. That all comes down to, like you said, it's empowering patients and taking a more collaborative approach. Right. I think the core piece of consumerization in healthcare is giving patients and providers, patients really, agency. And agency requires information and some bit of education. And to a great extent that we're seeing that take hold. I think getting back to the place where physicians and those frontline resources are considering the opportunity as more of a collaborative one, where they can help people make the decisions that are best for them based on their unique needs and perspectives. And empowering that is what will, I think, drive a kind of a more pleasant care access experience. But at its core, I think I totally agree that having that dedicated resource that is repeatable, that knows you, that has access to your information, that you can pick up the phone and chat with through text or call or video chat. It doesn't have to be in person. Like you said, digital is fine, but just having that resource to help guide you and distill some of the information that people drown in from what's available now on the internet with Dr. Google and WebMD is important. And but I think you touch on a bigger point around connectivity and allowing for the collaboration to exist, not only between the patient and that frontline provider, but the patient and the entire ecosystem. And I think using the ecosystem to get back to our concept of holistic care in the context of the opportunity that exists in the self-insured employer space, with them representing the largest buyer, to bring it home. How do we affect that type of model, that kind of patient-centered, provider-centered model in the context of the self-insured employer space? I think we've seen it grow with the increase of plans that have advanced primary care, direct primary care, subscription primary care, whatever you want to call it, on the front of the plan, acting as that front door and the guide for patients. And it's been proven to drive downstream savings. I think it'll be very interesting to see how that accelerates and takes hold over the next few years. From what you've seen in your conversations, I know you speak with a lot of the big names, whether it's CROs, benefits executives. Have you seen that? Are they aware of the shift that's taking place? Are they aware of the opportunity as it pertains to this whole person full risk consideration? And when you think about, I'll say one more thing, when you think about self-insured employer, like I've always seen this space as the perfect breeding ground for innovation, because these providers or these employers, they're taking full risk, right? People talk about value-based care and taking risk and Medicare in the context of Medicare Advantage, when in reality, it's like we have the largest buyer in the country that actually exists in these micro pockets on a local level. That's the perfect opportunity to really try out some of these newer and more innovative care delivery models. And so just curious to hear what you've heard from executives in this context.
Executives on the employer side or on the
So thank you for clarifying.
Yeah.
Both, because I know we touched on the executives on the insurance carrier side a little bit last time. I wanted to touch on that a bit, but
Sure.
Let's start with the buyer, the self-insured employer side first.
Absolutely. Any employer, big or small, recognizes the fact that their employees are fundamentally their best asset, right? These days we're talking everything AI, right? That's all great, but ain't going to be taking over anytime soon, right? The only thing that AI is going to do is make us more productive, right? So at the end of the day, the employee is considered an asset for any half-decent employer who has a growth trajectory, right? And therefore, any employee that is sick is a cost, Any employee that is healthy is a revenue generator. I think we will all agree that this is notionally true. This is how employers operate. Now we are in a situation where employers recognize that the cost of health care is growing at a rate of 2x, 3x of nominal inflation. That is not acceptable. That is not sustainable. That will not work out because they're operating on a finite budget, and that finite budget has to pay for increase in compensation year after year, provide benefits at the same time, right? You can only do one of those two things in a manner that is reflective of your care of your employees. And so employers have arrived at this juncture. Again, I made a jump that our audience recognize the fact that for the last 14 years, and we've been tracking this since the Affordable Care Act became law of the land, where employers are beginning to, especially after the financial crisis here in the US in 2008, 2009, when employers came out of that the financial crisis with more money in the bank, which is an irony in itself. And they began to ask themselves, why am I going to give somebody else the privilege of underwriting my own risk, my employee's medical risk, when I already have enough money in the bank? So that is the genesis to where we are right now, which is to your point that almost 27% of all employers, 27% of all US residents their medical risk is underwritten by their employer, right? So we're at a point where employers recognize that this is an opportunity. Now, you also alluded to another very interesting point is that even though the self-insured employer market is the largest at this point in time, they don't go to market as one entity. They go to market as individual entities, right? And therefore, not all of them have the same level of appreciation, understanding, and risk tolerance, right? And so at HFS, we've created 5 different archetypes to reflect the different kinds of self-insured employers. On one end of the spectrum, we have, I would call them conservative employers, typically who have employees in a space where physical labor is necessary, whether it's manufacturing, retail, and so on. And those folks are likely going to continue to follow what they've been doing forever, which is even though they're underwriting medical risk, they're going back to a health plan and saying, look, I'll buy ASO services, we'll go fee for service, same, right? Because typically tenure, the expectation of employees, the kind of illnesses and injuries that they attract are very different. And then on the other end of the spectrum, we're the most progressive here are generally services, high-tech folks, high-tech employers whose average employee age is younger, who are willing to experiment, who are willing to tolerate a different level of risk, right? And they are likely going to go to, say, a quote unquote, a marketplace and buy what they want as they need for their specific purpose. This is how we see the self-insured employer market going to slowly evolve itself, right? Maybe there'll be more archetypes, or maybe the archetypes will collapse into themselves, because don't forget, right now in the US, there are 5 different generations in the workforce. 5, never ever happened before. Don't know if it'll happen again in the future, but 5 different generations. And yet employers so far have been buying a one size fits all, which is not working out, right? And out of that 5 generations, 55% of the employee workforce is younger people. They are Gen Zs and the millennials and Gen Zs, right? This is smaller, younger population. They're not buying healthcare. They're not healthcare consumers. They're health consumers. They're well-being followers, right? So it's an entirely different mind space that they're operating in, right? So we're looking at the self-insured employer market across these 5 different archetypes. Now, going back to the health plan side of the equation, of course they know about it. They've known about it long before you and I got to hear about this, right? Let's not forget, even though they're health insurers or health plans, they're essentially a financial services enterprise. They look way out into the future. And they've known about this for a very long time. And you know how we know about that? We've seen them in action with the amount of vertical integration that has been happening. We've completed a study just very recently that included interacting with 360 health plans and health systems, right? Health insurers and hospitals and health systems, 360 of them. Almost 50% of all health insurers have participated in some vertical integration over the last 3 years. 50% of them. Vertical integration is essentially them buying an unlike business, health insurance buying a hospital, health insurance buying a pharmacy, whatever, right? So they're basically trying to create an ecosystem that diversifies their revenues. Why on earth would you do this if your primary business, which was underwriting medical risk, which by the way is high margin business, was still a viable business? It is not, which is why they're diversifying it, right? So they've known about it for a very long time. They are now trying to create these vertically integrated enterprises so that their value proposition will shift towards potentially the future needs of the citizenry, if you would, right? That's where I see these market dynamics playing out. They are for sure happening, right? From a services standpoint, there is a vast amount of players who continue to focus on the legacy because they are uncomfortable with the future. And two, from an employer standpoint, the opportunity here is that they are looking for suppliers. They are desperate for suppliers. They need someone to hold their hand, and that someone holding their hand is not a health insurance company. They want someone else, right? So I see enormous amount of energy here. They are scared. The risk tolerance is low, but at the same time, they recognize that this is a transition moment for them if they need to continue to remain competitive going forward. They being the employers.
Got it. Yeah. And one thing that you touched on last time was this concept of on the service provider side with the Optums, Evernorth, Carelon, et cetera, and them shifting away from managing risk towards providing administrative services, et cetera. They're still operating on this old school chassis. I feel like that's the final piece. Yeah, they've vertically integrated their organizations, but they haven't vertically integrated the infrastructure. To some extent, they have, right, with certain systems, but I feel like that's the piece that is lagging and also represents the opportunity. But to what extent do you feel that is a function of leadership thinking that it'll be by the time that they're out, by the time that some of them retire potentially, that they'll kick the can down the road enough for it to be someone else's problem, and that they're taking steps to address the shift now, but not necessarily making massive changes. When I say infrastructure, I literally mean transactional infrastructure, claims, et cetera, sharing of data, that connectivity concept. Do you think it's because they see it as someone else's problem, or is there this perception that what we have is, currently is fine, and that all we need is to just continue to consolidate and acquire and vertically integrate? We've seen varying levels of success with regards to vertical integration, and so the jig's up in terms of which true capability, at least given or on top of the existing infrastructure. I think as we shift away from that, we'll start to squeeze more of the value out. But I'm curious, what's the perception around, not my problem, this is good enough for now, let someone else deal with it, with regards to infrastructure?
I think it's a little bit of all of those things, right? Because buyer intent has changed, buyer behavior has not changed. Employers are without doubt looking for new partners, but they haven't found new partners. That is a huge opportunity in the marketplace. It's a huge void. And until they find those partners, and those partners at scale who are able to create and deliver value that is aligned with sort of the futuristic goals and objectives of that employer, they are unfortunately stuck with the old school, right? You mentioned Optum and Carelon and even Evernorth, all of these services, technology and services arms of large health plans in the country. These are huge enterprises. Optum's $237 billion or so in 2022, 2023, right? These huge companies. And they have put together extraordinary infrastructure that cannot be overnight replaced, may not even be required to be replaced. They have extremely talented people. But the question really boils down to, what is that future that we're trying to paint? What does good look like for us? I don't think we have aligned. As a society, we haven't aligned. As a healthcare business, we haven't aligned. And where I see this going is not so much kicking down the can down the road, as much as pushing the can down the road, looking for opportunities in a tactical manner versus making strategic bets because you just don't know where it's going to go.
Got it. Yeah, and
And
that
look,
opportunity.
I'll be honest, if I was an employer, if I was the CEO of an enterprise of say 1,000, 5,000, 10,000, 20,000, I would be having the same conversation with you. And then I would turn around and say, Sydney, do you know anybody in the market who can help me with what I'm trying to do? I really want to create an opportunity for my employees where they can address their own health and care needs in a manner that fits their pocketbook, that fits their lifestyle, that fits their age, whatever. And my suspicion is both you and I are going to say, I'm not sure I have one of them right now. Maybe you, Sydney, with Mish, you are able to do that in a short period of time. But right now, that is what the employer is looking for. Find me someone who can help me.
Amen. Yeah, and that's the space that we will be stepping into and have stepped into and will be.
I can't wait.
Guessing.
I can't wait. I can't wait, Sydney.
One final thing, I want to make one comment because you touched on the employee representing the best resource that an employer has, the best asset that an employer has. And it reminded me of a quote from Elizabeth Mitchell. She's the CEO of the Purchaser Business Group on Health in a podcast with Stacey Richter. I'm a big fan of Stacey's. Shout out to Relentless Self Value. But on a podcast recently, she said that employers pay more in lost productivity from members unsuccessfully navigating or trying to navigate the healthcare system than they do on the actual care itself. And with close to $400 billion you spent in that regard, represents a massive lost opportunity. I think that concept of navigating the system harkens back to what we were discussing with regards to the care guide opportunity and putting primary care in the center. And so to your point, I'm sure that they all realize the opportunity there. It's just a matter of pushing it forward. And yeah, looking forward to seeing what that future looks like. Looking forward to keeping in touch with you and keeping the conversation going. I really appreciate you taking the time again to speak with us and share your perspective. I think it's been super powerful for the listeners and even for myself. I've been taking notes this whole time. Looking forward to following up. Any parting thoughts? And then I'll ask where people can find you if they want to interact with some of your content on LinkedIn. I'm not sure if you're on Twitter, but I know you have a lot of great articles, and that's how we connected.
Parting thoughts is, I think we're at an inflection point. We, the people, right? We, the employer, I would say collectively, we're at an inflection point. And that inflection point gives us a choice. We can regress back to the way things were because we are satisfied with the outcomes, or we be the pioneers that America has always been, and we choose something new so that we can attract new kinds of outcomes that are aligned to our health and healthcare objectives. That is what I say. We're at that inflection point.
Amen. Totally agree. And where can people find you? I know you're on Rohan Kulkarni. Where else?
I am also at HFS Research /Rohan Kulkarni.
Amazing. Awesome. Thank you again, Rohan. I really appreciate your time and looking forward to keeping the conversation going.
Absolutely, Sydney. Thank you very much. Appreciate it. And my continued good wishes to you and to Mish.
Thank you so much. That wraps up today's episode of Off the Rails. Remember, you can find us on Spotify, Apple Music, YouTube, and other major podcast channels. Don't forget to subscribe to catch all the content. If you like what you hear, please leave us a review and share it with your friends. Your support means a lot and helps us deliver more authentic takes from real change makers. Follow us on Instagram at GoOffTheRails and follow me on Twitter at Sydney Haytalk. Thanks again for listening. Stay genuine and stay true.